Hi, this is Bruce Quinn, and I hope congratulations are in order if you've gotten to the fourth video in this four-video series, which is called Communication Frameworks for Clinical Utility. This video focuses on some specific examples. If that's possible, it may be the nerdiest of the four videos. So to briefly recap, in case you're coming back to this course after a few days or weeks, too often we hear your test lacks sufficient clinical utility, so you need more clinical utility. It's very vague, and it doesn't really tell you exactly what you should do next. There's no roadmap, and there are no guideposts. If we were playing the right game, we'd say, I understand the value proposition of your test, that 30% of surgeries will be safely avoided, but I'm not convinced it will happen. I'm uncertain specifically because of A and B and C. And that means you could address this by more information or more studies, particularly directed toward A, B, and C. This is a general diagram that we've used throughout the course. It says that you bring in a new test and you've got a gain in clinical validity, carefully stated and explained, and that has an effect on management, which would be ideal in an ideal circumstance, but probably a little less in the real world. Talk about that difference. It's efficacy versus effectiveness. And then that drives some improvement in outcomes, a gain in clinical utility, as we discussed in the last video. We walk through this diagram by having 6 questions. The first is who should be tested and under what circumstances. The second is what does the test tell us that we did not know before. The third is can we act on the information provided by the test in the ideal circumstance? If everything was exactly as we hope, how good would the outcomes be? Question 4 is more pragmatic, what will really happen in the real world. Question 5 is patient-centered outcomes, survival, less pain, or other values. And question 6 says, can we afford it? Simply, is it a reasonable value? Whether that's a budget impact model, dollars per QALY, or some other aspect. Is it reasonable? Remember that, as we'll see in this video, for questions 2, 5, and 6, we ask against what comparators, in what units, and with what uncertainty. We'll make this a lot more concrete by actually going through some examples now, slowly for the first time. The fundamental theorem of clinical utility is that clinical utility is always comparative. If you read articles about clinical utility, they'll mention that somewhere. But we're making this fundamental, and we're saying, what can we unwrap or unpack by using this as a starting point? Comparisons are always against some particular comparator, in some kind of units, even if they're qualitative, and with some uncertainty. These are always the 3 aspects of comparisons. There are recurrent issues. I talked about these in video 1, so I won't drain them again. But the developer wants probably the most impressive or easiest comparator. The payer will want extensive data, more population, more duration, multiple scenarios. The units could be very diverse. Survival, less pain, less adverse events, faster diagnosis, less impact at less same impact at less cost. And we'll really dive down now into the bottom question. What are the kinds of uncertainties and how can we make them more explicit? Statistical uncertainty is something like 50% longer survival, plus or minus 10%. Pragmatic uncertainty is the external validity. Will it work outside the trial? Will it work in rural areas? Will it work with family doctors? And conceptual uncertainty is all the kinds of uncertainty that are still left. And we'll see some examples of that as we work through molecular tests. Because of the special complexities of molecular tests, this third bucket is probably bigger than it would be in other kinds of healthcare. The theory is that all tests have clinical validity that is better in some way, and that drives clinical utility, which also should be better in some way. And the left side of the chart drives through an arrow and becomes the right side of the chart. The problem that recurs, it's not whether something's a randomized trial, it's not whether there are 100 patients or 160 patients, it's whether, if you're talking to a reasonable skeptic, is the story convincing? And how do we make it convincing? We walk through the 6 questions and we show answers to all of the 6 questions. So let's dive in. Take a deep breath. The first case study is a hypothetical gene panel test for biopsy-proven prostate cancer. So a man has had an elevated PSA. He's chosen to have a prostate biopsy. It has some intermediate grade, a small tumor, and he and the doctor wonder what to do next. The last 10 years in the United States, many of those men have had prostate surgery or prostate radiation or sometimes both. And we hope that we could have a better prognosis and leave more of the men alone, send them home. They don't need a more invasive procedure. So question 1, who should be tested and under what circumstances? Patients with biopsy positive prostate cancer. And let's say we'll exclude the patients with the 10% lowest and 10% highest grade lesions because they will already enter watchful waiting or definitive care respectively. So how does that look? Well, the population is pretty clearly defined, and it's reasonably likely to be reproducible based on how we've defined it. As I said in the first video, these are hypotheticals. I've set up the questions so they can be answered in 10 or 15 words. We'll walk through them in 30 seconds per question, but it does give a guide to how you might use the framework over a day or over a 30-page report in real life. Question 2, what does the test tell us that we did not know before? Well, what's the comparator? It's the Gleason grade, which is correlated, at least loosely correlated with risk. And what's the novel test? It's this gene panel risk predictor. So we know what we're comparing to and we know what the novel test is. In what units? Well, prognostic tests, we said, can be tricky because what are the units? You have a higher R value for correlation, or R squared. You have a tinier P value, like P.01 instead of P.05. Those aren't very actionable. So we may move to a reclassification index, and that's the units. About 40% of the patients are reclassified from intermediate grade to low grade disease. Now, with what uncertainty? The statistical uncertainty is low. We've done 3 large trials. Each one had 500 biopsies in it. We had 5 or 10 years of outcomes to track to. So the statistical correlations are pretty high. So the issues, the test reclassifies about 40% of patients up or down in a more accurate way than Gleason grade, and it has been validated repeatedly in several large published cohorts. So let's go on to the next question. Can we act on the test in the ideal world? Well, the answer that the company provides, if we knew prostate cancer was very likely to recur or very unlikely to recur, we would act differently. The choices would be watchful waiting or proceed to surgery. And we've done some modeling. This should happen, this change, at least 20 or 40% of the time. So again, we're only talking about ideal outcomes here. But yes, ideally, the prognostic information could support substantially different treatment decisions, including no surgery. And it's been based on data and professional consensus. Behind this PowerPoint slide, there are 4 or 5 peer-reviewed published studies. Question 4, can we act on the test in the real world? Well, regarding this choice, let's say that the company has got data where they looked at 40 community clinicians, and they had a total of 400 patients, and they did change plans about 40% of the time. And these were actual patients making actual care decisions. So we have real-world data that it's impactful on decisions and therapy choices in the community, at least in one trial. In this trial, they had 60 days of follow-up, so we may not be sure how long those decisions stick. Of course, if you had a decision to have surgery, that's going to stick. But if you have a decision to wait, you might want to monitor that for longer. Excuse me. Do the outcomes change in a way we find value in? Well, in routine care, 90% of patients will say get a prostatectomy. With the novel test, we have 30 or 40% fewer surgeries over a period of months. With what uncertainty? The statistical uncertainty is low. The 30% is plus or minus 5%. But the later impact on the surgery rate 1 or 2 years in the future is unknown. We haven't studied that, so that's an uncertainty. We'll conclude the test seems impactful with a substantial proportion of patients avoiding surgery because they're low risk. The clinical unit is surgeries avoided. It probably could also have been expressed in QALYs. And remember, we don't know what happens 1 or 2 years in the future. Is it a reasonable value? Well, let's pretend the company has data on that. Let's say if 10 patients get the $3,000 test, it costs $30,000, but 3 of the 10 patients do not have surgery, so let's say they save $90,000. So the net savings looks like $60,000, and then you can add and subtract some other costs. And of course, what's the uncertainty? We have only 6 or 12 months of actual data. What happens in the second, third, and fourth years is unknown. So we conclude the test seems cost-saving, but only first-year data is in hand. So the summary, we've just walked through this, so I won't repeat it, but they suggest that we seem to have, in this hypothetical example, reasonable answers across all 6 of the questions. There don't seem to be huge uncertainties, except maybe the second, third, fourth year outcomes. We might cover the test, but want data accumulated on the second and third, fourth year, for example. But then we've narrowed that down to the main question that still remained after going through the 6 questions. Test case 2, I have deliberately set to be negative. So we'll walk through this from a skeptical perspective, but it is key to a Medicare national coverage determination that was made in October of 2013. Looking at the new beta amyloid PET scans, they decided Medicare would not cover those except in some controlled randomized trials, which would be much less than the multi-million patient potential population. So who should be tested and under what circumstances? Well, there are some guidelines beginning to come out, and I'll present it this way for the sake of argument. I'm being the devil's advocate here. It's for patients who have symptoms of cognitive dysfunction and are possibly or probably Alzheimer's disease based on consensus rating tools, and the diagnosis is problematic in some way, but it's not the patients who seem to have uncomplicated cases. And the patients had uncertain prior imaging or workup, but we assume whatever it was, it contributed to the uncertainty. So the issues now, comparison to some other things we've seen, the population sounds a little vague. It might be difficult for payers to control in the real world and monitor and enforce that definition. The future clinical target population is not the one tested in pivotal accuracy studies, which involved in part autopsy studies of people at the end of their life, not 60 or 70-year-olds who had early cognitive impairment. So the answer to the first question, we're not going to rate it, but it seems a little soft. The second question is what the tests tell us that we did not know before. And I have to admit, this slide surprised me because I didn't know the answer before I started writing it. So the comparator is routine physician diagnosis, which could be possible Alzheimer's or probable Alzheimer's, but not if it's uncomplicated. The novel test is a binary beta amyloid positive or negative PET scan. So right there, look at the comparator, look at the novel test. The units are incommensurate, so you're going to stop. You can't really say how much this is better than that because the units are incommensurate. With what uncertainty? Well, you've got some uncertainties. There's a kappa value between different radiologists reading the test. There's issues about what kind of training you'll have. There's some uncertainty because here, the actual clinical validity of the test, you can't just immediately autopsy someone the next day and find out if the test was correct or not. So in a sense, there's no gold standard. For the comparator, the units are incommensurate. I just belabored that. And the test was not tested in the proposed clinical population. So the issue is it's very hard to compare the clinical validity of the control test, the physician diagnosis, and the new test since the units are incommensurate. There seem to be uncertainties, including the fact the clinical population isn't the same as the validation population who was used in the studies, like the autopsy studies. And so stating the objective delta of the improved clinical validity, that's this little red up arrow, saying exactly what that red up arrow is, has gotten pretty messy. However, I'm going to insert another slide here. So could we state the comparator in a way that you can make the comparison in some kind of units? All the data, all the numbers on this slide are made up. But I'll show what you can do if you had this data. So let's assume that possible Alzheimer's disease is a 50% chance of Alzheimer's, and probable Alzheimer's disease is an 80% chance. And assume you have 50 patients of each type. And now assume that when you gave all 100 patients, 50 possible, 50 probable, the test, 20% in each group would rule out they're not Alzheimer's disease because they're amyloid negative. So here we have, before the test in words, 50 patients with possible Alzheimer's disease, 50 with probable Alzheimer's disease. That's the clinical diagnosis, the comparator. But we're going to change it into math. So here you've got 50 patients with a 50% chance of Alzheimer's. And probable, you've got 50 patients with an 80% chance of Alzheimer's. Let's assume that's right, because now we've converted it to math. So after you have the new test, you'll have 10 patients in the first group that are amyloid negative and 40 patients that have been filtered out. And you've pulled out the patients that were amyloid negative. In the second group, you've still got 10 patients who are amyloid negative and 40 patients filtered out. They are not amyloid negative. So you do the math. Now you've got 10 patients in the first group that are not Alzheimer's disease. You've got 40 patients left who now have a 60% chance of having Alzheimer's disease. In the second group, you have 10 patients who don't have Alzheimer's disease. And since they only had, you only expected 10 of them not to have Alzheimer's disease, it would imply that all that are left now do have Alzheimer's disease, if the numbers here were correct. So these shifts in groupings and probability are what the test tells us that we did not know before, and it's shown right here in this column in math. So question 2 and using the 3 aspects of comparisons force us to at least put the base case and the new case into the same units, which are these probabilities. So it would be those units that we just saw that would be driving the process toward the right. The third question is, can we act on the test in the ideal world? Well, the neurologist's knowledge has altered from before the test to after the test, and we just mocked that up. If the neurologist has a new group of downgraded, not Alzheimer cases, and he has a remaining group with higher confidence in his probable diagnosis, so exactly what will he now do optimally to improve the care of or either of both or either of the shifted groups of patients? And you can give the answer to that. I can't give the answer to that. I'm not a neurologist. But we know what the questions are. How would you treat the downgraded, not AD patients differently? How much impact does the marginal increase in Alzheimer confidence in the amyloid positive patients have? And the technology assessor, unless he had more information, couldn't go a lot further. What happens in the real world? We have some data that hypothetically the management changes some of the time, in fact 60% of the time, if scan data were available, and that's been published for the Medicare coverage decision. But Medicare argued the data was hypothetical, it was on paper, they felt it was weak, and they were concerned that some of the management changes being scored might be fairly small, and they weren't sure how much impact they would have on patients. If you don't know the impact, then it's hard to assess the risk-benefit. Do the outcomes change in a way we find value in? The comparator would be the care after routine clinical diagnostic workup. The new group would be how PET changed management, and you'd say, in what units have the patients become better off? Is it the value of knowing? Is it less patients that have a prescription that would have had side effects? Is it some other net benefit? So we don't have a lot of quantitative data on that yet. So it's not easy to extrapolate in this area in terms of how the patients are better, in what units, how much, and with what uncertainty. Is it a reasonable value? That's to be determined. You would need more data probably to do a pharmacoeconomic model. So the summary is that if you look at each of these 6 questions, and again, it's a mock-up and a hypothetical for teaching purposes, you would predict that payer coverage is difficult, but maybe we were biased because we knew that the payer coverage was already negative. I've already shown in slides 3 and 4, in video 1, I showed this third and fourth case study already, so if you remember it, you don't need to listen to it again and you're finished. If you'd like to hear it again, the third example, where I only have one slide, is non-invasive pregnancy testing, where the population is women who would get amniocentesis because they have a high accepted pregnancy risk level for Down syndrome. That's pretty clear. What's the delta in clinical validity? The NIPT tests are extremely accurate. They've been studied in large populations. They seem to be 98, 99% accurate. Can we act in the ideal world? Yes, we could replace amniocentesis with NIPT. That's the answer. Will we act in the real world? Yes, in a big way. Guidelines move this way. Women and doctors are already making these choices. Do the outcomes change? There's a lot less amniocentesis, but they seem to feel they have equally good data for decision making. Pharmacoeconomically, I don't have in front of me, but at least a significant part of the cost would be direct replacement costs, shifting from amniocentesis and all the lab costs to the, for most patients, the one-time molecular test. The last example is the Veracyte Afirma test. This is a molecular test that you roll out if the patient has an ambiguous biopsy for a thyroid nodule. About 15% of thyroid nodules that get a biopsy will have an ambiguous biopsy. And those patients tend to move to surgery because you're concerned they have cancer and you have not ruled it out. Can you quantify the delta in clinical validity? Yes, the gene panel test resolves malignancy issues in patients with an ambiguous FNA a lot of the time. They're very large data sets. The whole thing's published. Can we act in the ideal world? Well, yeah, we defer surgery. If you don't have thyroid cancer, you don't need thyroid surgery. Will we act in the real world? Yes, there's data on that published. Actual doctors and real patients generally defer surgery based on this test, just as predicted. How do the outcomes change? The metric is less surgeries, and there are a substantial number of surgeries avoided. The pharmacoeconomics has been studied. It's very helpful that the avoided surgeries are pretty expensive, and when those are avoided, it helps neutralize the costs of genomic testing. And of course, you'd give some quality adjusted life years or quality of life value for avoiding a major invasive neck surgery. So these 6 questions would predict that the Veracyte test would do pretty well. And in fact, it had a series of 4 or 5 publications in a year or two, got into national guidelines from the NCCN, and then Medicare and substantial private payer coverage came pretty quickly as well. So it looks pretty good on this mock-up that I could write in 3 or 4 minutes, and it actually got covered pretty well in the real world. Thank you for watching this course, and keep track of updates at discoveriesinhealthpolicy.com. Thank you.